Jorge Sarmiento with Ability Rehabilitation Specialists, and he's going to give a presentation on physical therapy and the benefits of it. And he's here locally in La Jolla. So any of you that live nearby, you might want to pay attention and take a card. I have some cards with me. So I'll hand it over to Jorge.
Hi, how are you? Okay. One of the first things I would like to ask you is how many of you have had physical therapy in the past? 1, 2 people, 3 people. Okay. So one of the things that we do in physical therapy, besides doing exercises and balance and doing manual therapy, is introducing what type of activities we are going to engage for that particular ailment. So we do a full assessment of the patient. Let me see how this works. Okay. Let's see. All right. Okay, so when we do an evaluation, one of the things that we're looking for is taking in consideration if the patient has any spasticity, which is velocity dependent on a particular patient. So we are going to take a look to see if the patient has weakness and if there is ataxia present as well. So an ataxia is going to contribute actually to falls, and it's something that we have to take in consideration very closely to make the person learn some strategies to avoid falling. The gait disturbances are also present in many of the patients, and for that we have some equipment that will allow them to walk supported and avoid falls, and I'm going to show you that later on. Progressive stiffness is another thing that we start looking, especially on the arms and elbows, shoulders, knees, and ankles. And it differentiates from spasticity in that there is no velocity dependency on it. So if you're going to move the limb, it's going to be stiff in any direction. Paralysis of the lower extremities and overall generalized weakness. So when we are going to evaluate the patient, then we're going to take a look at the muscle strength. And we take a look at the whole patient, not only the area that is involved. So many patients that arrive to the clinic, let's say they present with pain and difficulty moving the shoulder. I'm going to evaluate not only the shoulder, but also the neck, upper back, lower back, and go all the way down to the ankles. And the reason for that is because in the past, we have found that when the limb, the distal limb, especially the legs, are also affecting the shoulder. And you will see that, and the reason for that is because of myofascial restrictions in the body that they've been accumulated over time due to injury. And the range of motion, we evaluate the range of motion, especially of the areas that are limited. But also, if we find any gait disturbances, then we're going to go down to the patient's ankles, for instance. Static and dynamic balance ability. One of the most important things to prevent falls is making sure that the person has not only good balance, but also good proprioception. And there is a difference between both of them. The endurance. The endurance is a great component of balance. When endurance fails or is slow and strength is low, balance is also going to suffer. However, there are times in which patients don't have any weakness, don't have any lack of endurance, but they're losing the balance. So we have to take a look at the vestibular system to see if that is what is affected. On the gait disturbances, there are many types of disturbances, unfortunately, but one of the things that we initially do, especially if the patient is falling, is allow them to explore the possibility of using an assisted device. It can be a cane, it can be a front wheel walker, or a 4-wheel walker, or a 3-wheel walker, or walking sticks. And nowadays, people are using more the walking sticks. And I actually recommend them more because when they use a cane, they have the tendency first of using the cane improperly because they're using in the opposite arm or in the arm that is not supposed to be used in. And they lean too much into the cane or it is poorly fitted. So a walking stick allows the patient to walk straighter and they can have a better gait and better cadence. We take a look at muscle tone. If there is spasticity, we have some techniques to reduce the spasticity of the limbs as well. And of course, if they are hypertonic or they have rigidity. We take a close look at the arthrokinematics, meaning how the joints move in relationship to each other. So for instance, if the shoulder has poor arthrokinematics, and then there is not enough gliding of the head of the humerus on the glenoid fossa, therefore it won't allow the shoulder movement to be nice and smooth. So we take a look at those arthrokinematics. Motor control. If the person has some ataxia or weakness, and then the lack of control on the distal limb is going to be present. So perhaps they don't have enough strength to reach for an object. Therefore, that motor control is going to fail. Sensory deficiencies. Many times, when the feet are affected and they have numbness, tingling on the soles of the feet, then the proprioceptive input into the body is going to be affected gravely because, and is going to result usually in falls. It results also in deficiency in the gait pattern. So imagine some people having poor sensation on the bottom of their feet. So what is going to happen to that person is, since the proprioceptive input is not present, when they take a step, they might feel that they are floating. For some others, it's pain. For other people, a burning sensation, which is going to limit their ability to ambulate properly. Soft tissue mobility. I do a lot of soft tissue mobilization. And myofascial release is one of those activities that I actually perform in most of my patients because I have found out that when a limb is lacking range of motion, then the collagen tissue underneath starts getting stiffer. And as soon as I move and mobilize that tissue, the limb starts moving better. They feel better. Pain is reduced. Spasticity also gets diminished. Dexterity, for many patients with lack of sensation on their hands, is also lost. So we have some dexterity tests that we do, a Minnesota test that we ask them to perform to test their dexterity. And then we have tools also to allow them to practice and start moving their limbs and the fingers with more accuracy. So some of the therapeutic interventions that we have is strengthening. And many times, strengthening is being kind of watered down, just doing some weights and lifting weights and things like that. Strengthening requires also that when we teach our patients to do an exercise, that they will perform those exercises with proper body mechanics. Because it's not only just lifting weights, it's making sure that when they are lifting the weights, then if they do it properly and with the enough amount of resistance, then they will fully benefit. I have had many patients that are extremely weak. And one of the complaints they have is that sometimes they kind of push them a little bit too much to do exercises that are going to actually send them back. So when I encounter a patient like that, I tailor the specific exercises for them to have enough muscle soreness so they have a little bit of residual feeling of something is working, but not too painful that the patient is going to quit coming to physical therapy. So, because it is, yes, one of the things is I hurt too much, this is not helping me. And yes, unfortunately, there are so many people that perhaps they haven't engaged in exercise in all their lives, and suddenly they encounter pain after doing exercise, and then they equate that with this is not working for me or this is injuring me. So I tell them, just do the exercise, and if the soreness lasts more than 24 hours, maybe 48 hours, and then we went too far. But if it's just a muscle soreness that after 24 hours it resolves, and then you are doing fine. So we start usually with isometrics if the person has poor tolerance. Is anybody familiar with isometric? What that isometric is? So an isometric exercise is one in which the joint will not move. So for instance, I'm going to bend my elbow. So this is the range of motion of the elbow. And I want to strengthen the muscle. Let's say that my biceps was hurting. Then I will put just a tiny bit of resistance, and then the muscle will contract. So isometric, it means of the same length. So the muscle length has not changed. And you can put just maybe half a pound of resistance. I ask them, just imagine you have a half a pound weight, and you're going to lift it, but don't lift it. Just create some resistance. As soon as the muscle receives that input, the muscle will contract or contract. It won't happen that the muscle is going to relax. So it is an all or none. So if it is going to contract, it will contract. That's it. So you don't need 10 pounds or 5 pounds or 20 pounds to make that happen. You just can touch actually the limb, push against it, half a pound, a quarter of a pound, and the muscle will contract. So from then on, we can do isotonic, concentric, and eccentric exercises. Concentric exercises, probably the most widely known, is just bending the limb that we are working, lifting the shoulders with weight, kicking with the legs, etc. So that will be a form of concentric exercise. An eccentric exercise will be one in which the resistance is given in the opposite direction of the movement of the limb. For instance, if I have a 5-pound weight in my arm, if I want to do a concentric first exercise, and then I will move my elbow up. If I want to do it eccentrically, and then I will lower my arm slowly, and then that will make it eccentrically. That is a stronger exercise that I usually utilize just at the end of the rehabilitation, when the person is strong enough to have that kind of exercise. Now, I have a Pilates table in the clinic, and sometimes that kind of exercise can be injurious to the patient if the resistance is too high. So we have to make sure that every time we put a patient there, which I have placed 92-year-old ladies in the Pilates table, yes, and they do well. I had to support them a little bit, give them instead of allow them to put the head on the board of the Pilates table, I put a pillow for them, or I put extra cushions for them. I help them get in and get out, and they do the exercise. And one of the fascinating things is just looking at their face. They are doing that type of exercise, and they're with the legs up there, swinging around, moving their arms, and they just love it, actually. So the advantage is you can really decrease the resistance. If you're going to do squats standing, you have to lift your full body weight. When you put it in the Pilates table, now you can use different strengths on the springs. And I have different colors, from stronger to lighter. And then I will load them with whatever they can tolerate. How does it feel for you? It's strong enough, light enough, too much, and then I can decrease or increase the resistance for them. And they're able to do something that couldn't do if they were standing up. For instance, doing a full deep squat, they wouldn't be able to do it standing. Or sitting in a chair without reaching for the chair to support themselves. But then when I put in the Pilates table, they will be able to squat fully and then return back to the starting position. Also mat-based exercises with or without weights, and PNF, proprioception neuromuscular facilitation. This is a technique that uses the strength of the person in a way that is natural. For instance, when we go upstairs, one of the things that the body does automatically is to raise our toes. Immediately, as soon as you're going to take a step, the foot is going to go up. So we position our hands, when the person is lying down on a table, we position our hands in a way that we allow those muscle groups to be triggered in the same way they will do it when they're moving normally, when they're going upstairs or when they are pushing. So by using our hands, we give them a tactile feedback. Therefore, they will follow the motion smoothly. It's a very, very, very powerful exercise, or a very light exercise, depending on how much I'm going to resist that motion. Let's see. So here is an actor. Yeah, ready. And I know you can see, perhaps, I have 2 springs right there.
Hey, Cody.
It's very light. And in this particular exercise, it's not only the shoulders that are working. You notice my legs are in 90 degrees. 90 degrees at the knees, 90 degrees at the hips, and the core is being engaged. So the quads are engaged as well. The arms are engaged. Okay, let's see, next one. And on this one is the squats that I was telling you. So it's very, very, very light. I use also 2 springs.
I'll do 3 of them. Don't stop it. Focus on my feet.
And then you can do heel raises. It's very difficult for a person without good strength to do a heel raise, especially if you step on a step and try to bring your heels down, to do that kind of motion. And you can do it with one leg as well. So it's very beneficial for a person who doesn't have much strength. So if they see themselves doing the exercise, that is a great positive feedback for them, because they notice that they are doing something. They're engaging muscles that probably they haven't engaged in a long time.
Stop it.
Sorry, this is a very raw video that I put together. Okay, now for endurance. One of the things that unfortunately many people with AMN, for instance, cannot do is walk for long distances. Either because they don't have enough strength, or because there is pain on the ankles, on the knees, or the hips. They don't have enough strength to put the heel first and then propel themselves forward. Therefore, we have equipment called the AlterG. The AlterG is actually is a NASA-based technology in which we use negative pressure to support the person inside of a bubble of air. And the person is going to be very, very safe, is very well supported, and we can reduce the body weight up to 80%. Those allow the patient to walk normally, unlike walking inside of a swimming pool. If the person is walking inside of a swimming pool, the water is going to give some drag, and therefore is going to change the mechanics of the gait pattern. When they are doing the exercise on the AlterG, the gait pattern is not altered. And actually, if the person had an alteration on the gait pattern, that person will be able to correct it by just giving them feedback, take a longer step, you step on your heel. So some things that it will be a lot harder when they're doing it on land, because if they lack the strength, and then much less they're going to be paying attention to me telling them, okay, now put your heel down, when they have to be thinking about balancing or pain on their knees or the ankles. And then we have, of course, the stationary bikes and upper body ergometers to do some aerobic exercise, and low load, high repetition workouts. if the person cannot walk, and then we can use their upper body to generate an aerobic workout. This is a patient, an actual patient. He's using the AlterG.
So
He
this
had
is
a
Guido,
herniated disc.
and had a serious back injury with a disc herniation, and he's using AlterG at 75% of his body weight. So, Guido, can you tell us how are you feeling doing the AlterG?
I feel lighter.
You feel lighter?
I can run, yes.
If you were not running on the AlterG, do you think you would be able to run?
Not like this at all.
Do you have any pain right now, Guido?
No, I'm doing well.
Okay.
75% of my weight.
Okay. Thank you, Guido.
My pleasure.
Okay. He had a severe herniated disc. He was having already symptoms down his leg. He couldn't walk properly. So he went, actually, he's still with me. He's completing the strengthening, because if the disc doesn't heal properly, eventually, if the person doesn't know the full mechanics of how to protect themselves, it will fail. So he didn't want to have surgery. Therefore, he underwent physical therapy. Initially, he did about 20 sessions of mechanical traction to relieve the pressure. And then when the symptoms started centralizing, so if the person herniates a disc and they start having sciatic symptoms, pain down on the limb, and if the symptoms start centralizing, and then is when we start intervening by getting their core first strong, and then after that, if the person feels that they can they cannot extend their backs, and then gradually we start introducing those motions that are causing symptoms. Our next patient, she has MS.
3, 2, 1. Okay, this is Sharon. Sharon has MS. She's been using the AlterG for how long now, Sharon?
About a month and a half.
For about a month and a half ago. So one of the benefits that Sharon has experiencing is that she's able to take longer steps, as you can see.
Yeah.
Her stride length is longer. And her steps are even. And this is a little harder to do on the ground using the walker.
Yeah.
Now,
Walking, you can't take long steps.
yeah, so one of the other benefits is that here she's been able to walk for about 25 minutes. And walking on the ground, she has only been able to walk about 10 minutes. However, she has expressed that 10 minutes?
10 minutes.
10 minutes. That after she started using the AlterG, also her endurance has improved. Is that correct?
Right, definitely.
Definitely. And she's able to walk just a little bit longer so far on ground level.
So the benefit of being able to walk for longer distances, and then is going to allow the person also to gain endurance. Although the body weight is supported, and on her case, I believe it was 60%, I can't recall, but I think it was about 60% of the body weight was supported. We can put an elevation also on the treadmill, and then allow them to work a little bit harder. Now, and she's not wearing an AFO. When she's walking with the walker, and then she really has to swing her hip out in order to clear the ground. And as you noticed right there, she wasn't doing that. She was elevating a little bit better, and she was able to take a better step, and very long steps. For balance and proprioception. So for balance and proprioception, we use different devices like the Dynadisc or an ARX or a Bose ball. And one of the things that we want to challenge the person is into activating the musculature that keeps us upright. So although we know that the muscles of the back are doing the job and the glutes and the legs are holding us up. The slow twitch fibers in our body, the ones that have a lot of more endurance, are not work enough when the person starts losing balance. So we challenge them by putting them in surfaces that are soft and uneven. So that musculature starts working for them. So even standing up on the Bosu ball, just steady, and if I put my hands supporting them, at that particular moment, all the muscles of the body are working. And I joke with them and tell them, even your facial muscles are working because they're trying to hold themselves. So every single muscle actually is working. In about 6 months ago, I started introducing Qigong and Tai Chi in order to promote also balance. One of the simple motions in Tai Chi will be just positioning the heel first and allow the person to concentrate on that position. It is a narrow base on that particular spot and just coming back. And then in the other opposite direction, landing on the heel and coming back. And for them to be able to accomplish something like that, it starts giving them that positive feedback that I'm looking for in order for them to progress and have more confidence and less fear of falling. And I talk about soft tissue mobilization. One of the things that I do a lot is myofascial release, not only on the areas of the body that are affected, but also distally. I look and ask the patient for histories in which, for the history, if they had in the past like an ankle sprain. And there have been studies in which demonstrate that an ankle sprain that happened long time ago is going to also result later on in life on knee pain, back pain, up to the shoulder and neck, just because the kinetic chain is being affected over and over and over. Initially, when we are younger, perhaps we don't feel it. But then as we get older, those things start just changing. The gait starts changing. The way we position one foot starts changing. So I take a closer look to the soft tissue as well. Some of the things that we do to decrease spasticity is axial rotations. What it means is, let's say there is a spasticity on the arm, and then I will just rotate the arm of the patient very, very lightly, and then the limbs start relaxing. I can do it with the legs, very, very soft, and then start just relaxing. So that allows the spasticity to be decreased, therefore allows also to work on improving the range of motion, decreasing the onset of muscle contractures, and more damage. Let's see what else. On gait training. On gait training, one of the things, unfortunately, that happens is we lose the ability to know how to walk. And then the manifestations of the lack of ability of walking properly is no walking, walking improperly, falling. If the person doesn't feel like it's taking a long step enough to support them, then what they're going to do? They're going to shorten the steps. But we are top heavy. Therefore, if we trip just a little bit and then now down we go, because we lose the ability to step forward in order to catch ourselves. So we have to make sure that the person knows the strategies in order to prevent falls. And then we put them, we can actually put them also on the AlterG and ask them, okay, take a long step without the treadmill being on, just floating right there. So now take a long step. So they're in a bubble of air, and then they can take that step. Or take a step back, and they can take the step back. Or we can put a gait belt and ask them to do the same thing. And then show them that when they take a longer step, then the balance is going to improve. So those things, unfortunately, our patients have the tendency of forgetting because they've been dealing with that for a long time and nobody has told them, this is what you need to do. We strengthen the trunk and the core. And for the core, we're talking about the abdominal musculature, the lower back musculature, the glutes, the hip flexors. And if we notice that during the gait pattern, there is an alteration of the gait because of the ankle being without the proper support, and then we can introduce some orthotics to allow them to on their foot and with the right load. Another techniques that we use is the PNF that I mentioned before. Will allow also the core of the body to be strengthened by introducing, like, for instance, dynamic reversals. So we push the patient back and forward and ask them to resist. I tell them also that when you come to therapy, I'm just going to push you around. We are going to use also stabilizing reversals just to allow the body to have that proprioception and that grounding. And rhythmic stabilization, we can do those techniques as well to promote the use of the correct musculature. Now, postural training and body mechanics via tactile, verbal, and visual cues. Many times, I take the visual cues out of them. And I ask them to stand up first and look with your eyes open, look to one side, and come back. If there is no loss of balance, and then I ask them, now close your eyes. And then they close your eyes and go, and then some people can't hold them, some people lose the balance. And then I start working on those deficiencies until they flatten out. And I can use an Eric's mat to do the same thing, to challenge them a little bit more. And in the technique that I use, I put them into the highest challenge they can tolerate, so that when they go into the ground, they feel this is a piece of cake. Now I can do this with my eyes closed. All right. And that was all regarding physical therapy. It happens that when I was doing the research, I found that clinical trial that was happening, I think, at the University of Stanford University, and they are accepting patients. So that was it. Any questions? Yes.
So I've got a question. I use a cane, and you mentioned that a number of people use it incorrectly.
Yes.
And either because it's sized incorrectly, or they use it the wrong hand. You use the wrong hand.
Uh-huh.
So I'm going to put you on the spot a little bit.
Sure.
So I've got a pretty pronounced toe drop on my right leg.
Okay.
And so I use a cane on my right hand, because I feel as if I need the cane to almost step over my foot, if that makes any sense.
Yes, yes, it does.
In your estimation, is that the right hand, the correct hand, or the wrong hand?
Yep. In order to, I'm going to demonstrate for you, just for a second.
Okay.
And tell me if this is something that is happening to you. So I'm going to presume that it's my right leg that is that I need to lift up. All right. So is this something that you're doing?
Actually, I advance the cane with the left foot.
You advance the cane with the left foot, and then support.
Yes.
All right.
Yes.
Okay. So what's going to happen then is either too much loading on your right side, which sends your body to your right side, and then it's going to start putting pressure on your lower back on your right side. Yeah. Have you have any pain on your back on the right side?
Yes.
So when you move the cane to the left, now you are using the stronger side. But unfortunately, if you are right-handed, the left hand feels very awkward. And unless if the person tells me, really, I cannot manage it with my non-dominant arm, and then I tell them, use your right, because it is a safety issue at the same time. All right? Now, if you were to advance the cane and the right foot, now you have a nice triangle of support. Your right leg is supported right here with the left with the cane on the left side, and then taking the step with the right. Okay? And behind me, there is another 3 points. Is that right? Another triangle right there. And then using the powerful leg to advance. Yeah. So
Thank you
sometimes
very
that
much.
works. Yes. And it's a matter of try. If you try it and it feels unsteady, and then I will not change safety for some back pain. Yep.
Thank you.
Yeah, you're welcome. Any other questions? Okay. Thank you very much for inviting me.